TV, Ortho TV, global live stream. Today, we are very, very lucky to have one of the most uh, talked surgeon, endocrine surgeon rather, and the one who founded the Surgical Ergonomics Society herself, the past president, Dr. Geeta Lal. We are privileged to hear from her and to have her time to talk on the topic, the burning topic, surgical ergonomics. And she will enlighten us and help us to how to prevent the injuries, being an orthopedic surgeon or a spine surgeon or just being a surgeon. Also, in panelists, we have Dr. Kushal Gohil from Mumbai. He is a renowned orthopedic spine surgeon in this area. We have Dr. Maria Auron from Israel. She is orthopedic spine consultant. And also we have Dr. Maria Camila. She is neurosurgeon from Colombia. So let's start the session. And it's all over to you, Dr. Geeta Lal.
Great. Good morning, good evening, good afternoon, everyone. And thank you very much to Dr. Sakhrekar and the entire panel on Ortho TV, Spine TV for having me here. So today, as you heard, we're going to sort of learn a little bit about ergonomics for the orthopedic surgeon. So let's get going. Before I jump in, I just wanted to share with you, you saw that picture with a bunch of lines on it on my previous slide. And what that is a representation of a software called Pose Checker, which I used during my coaching. It was designed by my partner's firm, EWI Works. And it uses AI-based computer vision algorithms to track body movements for ergonomic analysis. So the good thing is you don't need any sensors or equipment. We have the surgeons take a little video using their smartphones, and it really helps increase the awareness of harmful postures and assess impact of interventions. So you can see this is a video of me in my early days. They used my videos also to optimize the software. And, despite my giving talks as an ergonomics expert, you can see that my neck is constantly in the red zone. So there you go. Let's move forward. People often ask me why or how I became interested in surgical ergonomics. And, basically it's from my own journey. So almost 8 years ago now, I woke up with a familiar throbbing pain in the left side of my face and jaw. I had been diagnosed with myofascial temporomandibular joint dysfunction. Most of the time, the episodes resolved, but this time, the usual measures such as soft foods and NSAIDs weren't helping. And as the weeks wore on, the pain just got worse and spread to my head, my neck, my left shoulder, upper back, and it just refused to go away. My journey to feeling better has been involved, to say the least, but what I learned were a couple of things. One was that my symptoms were actually the end result of compensating for a number of injuries that I'd had both inside and outside the OR in my career as an endocrine surgeon. So I had my first lower back disc herniation in intern year, 1996. I had a motor vehicle accident. I had another disc herniation as a fellow. I was operating with someone who was 6 feet 6 inches tall. It's exactly 12 inches taller than me. And then just prior to this latest event, I'd had a rotator cuff injury and a frozen shoulder from a fall in a few steps at home. So what do we mean when we say or want to talk about ergonomics? So the International Ergonomics Association actually defines ergonomics as a scientific discipline concerned with the understanding of interactions among humans and other elements of the system. Now, for us in the operating room, our system could be our tables, our instruments, our environment, okay? So that's one definition. Ergonomics is also the name given to a profession that applies theory, principles, data, and methods to design in order to optimize human well-being and overall system performance. Now, I realize I'm speaking to an audience of orthopedic and specifically spine experts, so please take what I'm going to say with a modicum of salt, because this is how I use to explain things to my usually non-ortho audience. The root cause of our pain is something called forward head posture, which you are all familiar with. And I really like this graphic, which shows what the end result of that is, using sort of the analogy of text neck, which, all of us are using our mobile devices these days. What I was really surprised to see is that if you double the weight, sorry, if you just flex your neck forward by a small angle, 15 degrees, it essentially seems to double the weight of the head at the top of the spine. And then, of course, we all know that we are going to be in more than 15 degrees of flexion while we're doing our jobs. And as I said, this is for a non-ortho spine audience, but it's a good visual. The compensation occurs because you have a forward head posture, forward head tilt, the thoracic spine tends to jut outwards, and then the pelvis tilts in response to that, all of it in compensation. The end result, of course, is imbalances such as an upper cross syndrome and a lower cross syndrome, which I've learned from our physical therapy colleagues. Essentially ends up meaning that you have front muscles that are tight and back muscles that are weak, especially in the neck. And so then this results in all sorts of degenerative spine diseases. So what is the scope of the problem? I know we have three of our esteemed panelists here, so I'm going to ask, how common do you think musculoskeletal injury is among orthopedic surgeons or spine surgeons?
I request Maria to go ahead. She is a very learned orthopedic spine surgeon from Israel.
Thank you so much. Thank you for the question. And I personally think that musculoskeletal injuries are very common. And I think there is, I have seen research about it, and most commonly we're suffering from neck pain. There's also a lot of static work on the shoulders and the arms, and a lot of repetitive movements of the hands and the wrists. So I do think that it's a very relevant subject and very common.
Thank you so much.
Yeah. I request Dr. Kushal also to share his thoughts on this.
Yeah, so that is a very relevant topic because I personally myself experience, and I would also expect Raj, when we are doing cases, we have a lot of neck flexion, and especially when we use loops, we have a lot of neck pain after the surgery. So cervical disc degeneration, shoulder impingement, lower back problems, these are quite common in spine surgeons. We often neglect our own health while doing these cases. So it is a very common problem these days.
Yeah. And just to answer your question, So personally, yes, I like being a spine deformity surgeon, we operate for long hours, sometimes 8 or 12 hours, continuous long surgeries without breaks. And that kind of stiffens your back, lower limbs, as well as neck. And myself, I had mild C5-6 mild disc herniation, as well as back pain. And not just a spine, we have because of the ergonomics is like that, the shoulder pain, the wrist pain, because you're constantly working for long hours. Two of my bosses had surgeries for the carpal tunnel syndrome itself, because the caries and oranges we use, so they had the carpal tunnel surgeries. One of my other colleague had a L4-5 disc surgery done. One of the surgeons has C5-6 discectomy done. All these surgeries are occupational hazards and part and parcel of our occupation. So very important and pertinent and burning topic is this. And we are very thankful that you are creating awareness about it and talking about it. Thank you.
Right. Thank you to all of you for being vulnerable and sharing your own injuries. I find that this is a really topic that really has a lot of emotion and vulnerability attached to it. And for a long time, I didn't share my injuries. And I'm sure, other people in the audience may not share them either, because like you said, it's considered part and parcel, but that's part of the problem. So let's jump into it. Okay. So what is the scope of the problem? You've highlighted it, and the literature supports that. So if you look at orthopedic surgeons, I'm only quoting one article here because this is a recent article that actually reviewed the published literature since 1996, so 30 years worth of literature on sort of MSK injury among orthopedic surgeons. And you can see that, the average age was anywhere from 29, 30 to 56 years in various studies. Length of the career spanned early career to mid to late career surgeons. And the reported rates of injury were anywhere, or MSK pain from operating, I should say, were 52 to 97%, right? And the sites are exactly as you all just pointed out. So the back injuries, 17 to 77%, neck, two big heavy hitters, 10 to 74%, shoulder, hand, and wrist, all the sites that you pointed out. Now, I delved a little bit further to see, and this was the only study that I could find, and it's from a while ago, but it had sort of a multi-institutional survey study, and it exclusively focused on spine surgeons. And, just as you heard from our panel, neck pain and lumbar disc herniation radiculopathy and cervical disc herniation radiculopathy, just high numbers there. Rotator cuff, lateral epicondylitis. And what was even more striking to me is that if you looked at sort of the number of surgeons undergoing cervical disc surgery or spine surgery, the numbers that were quoted in this study are obviously much higher than those that we see in the general population. So clearly there is increased risk because of the work we do. Now, many people will say, by the way, if you looked at the risk factors for spine surgeons in the same study, they found correlations with a sedentary lifestyle. And just like Dr. Gohil pointed out, using loops tended to increase the risk. Now, a lot of you will say, well, these are survey studies, and they're inherently biased, right? Because people who have symptoms are more likely to respond to the surveys. And so I wanted to show you this objective measurement slide. This is a study from the Human Factors Lab at Mayo Clinic, and they studied over 53 surgeons in different specialties, over 100 cases, and they had them wear posture recording devices. And overall, it showed that surgeons spent 57 plus 8, 65% of procedure time in high-risk neck postures as classified by ergonomists. And then the same amount of time spent in high-risk torso and shoulder postures was 31% and 11% respectively. Now, this study, in addition to the objective measures, also had a survey component. And what was interesting was that surgeon self-reported pain was predictive of ergonomic risk. And so the subjectively reported sites of pain that you've heard from the panelists and that the literature reports actually have objective correlates. And contrary to what you might have heard during training or in the hallways, that surgery is a sign of, pain is a sign of weakness leaving the body. It isn't, right? It's a sign that something is wrong. So then that begs the question, why is it as a profession are surgeons of all specialties so prone to musculoskeletal disease? Well, one, you've heard sort of the panel point out that we don't really pay attention to ergonomic principles. The ergonomic principles are sort of that we work in neutral postures, we reduce excessive force, we minimize fatigue and static load, we work at the proper height, all of these things, right? And then I'm showing the video of myself again. And the thing is, because we are so focused on the task we're doing, we don't even know that we're violating these principles. We aren't aware. And when it comes to orthopedic and spine surgeons, you're doing a lot more than what I'm doing here. You have forceful manipulation of anatomy. You're using impact tools, which I don't use, so mallets, vibrating tools, bone saws. And you have a lot more prolonged gripping and pinching maneuvers using rongeurs than I use. Okay, so you have some added ergonomic challenges. We were just talking about kind of the surgical culture, accepting symptoms as part of the job, which means we push through, we forego breaks, and these traits are ingrained and then they're reinforced, right? Unfortunately, the end result is that less than 5% of us actually report our symptoms to anybody, let alone leadership. And then most of us end up self-treating, and very few actually seek out treatment, right? Isn't caffeine and ibuprofen the standard surgeon diet, right? That's what I've done for many, many years. A huge component of our injuries is our instruments. Now, I just wanted to share this picture that we took at the Society of Surgical Ergonomics booth at the SAGES meeting a few years ago. And these are trainees from the same program expected to use the same instruments, right? One is a size 8.5 glove, one is a 5.5 glove, right? And I think the women surgeons in the audience will understand this, but basically, the instrument related issues are because you can go to the market and get scissors and other tools that we use in daily life in different sizes and left and right hand configurations, etc. But surgical instruments are designed to meet regulatory requirements, such as maybe the need for sterilization. So nobody's considering the ergonomics of or the diverse anthropometrics hand sizes of the end users. And then even if the companies do make things in a particular, more than one size, unfortunately, then we are looking at OR stocking problems. It's more expensive to have multiple sizes available, etc. So this creates yet another kind of ergonomic challenge for us, our instrumentation. And then let's not forget the adjuncts we use. We've talked about loops and headlamps, adding weight as well as increasing spine flexion. If you're working in spaces that are retrofitted, for example, they put our imaging platforms in the OR after the ORs, the ORs are much older. So then when you're not flexing your spine, you're extending your spine to look at screens that are completely, placed out of range for you. You're using foot pedals. If you're using lead aprons, you're adding weight and stress to the spine. And then, of course, many of you use helmets and PAPRs for dust protection. And then that's adding kind of additional weight to the spine. We used to be relatively protected outside the OR. Someone else would do our transcriptions and our notes. Now, when we're not operating, we have the same ergonomic risk that we office workers get because we are sitting there charting on computers that haven't been set up for us, often in common areas. And then when we're not doing that, we're using our phones and, exacerbating that forward head posture by our constant texting. Then there are workspace and time limitations. What do I mean by that? Well, for example, if you took your car to a shop, they can elevate it, take the doors out, do what they need to do, and put it back together. Unfortunately, our patient's anatomy is what it is, and it can't be redesigned to optimize the work environment. Patients are unique, and so are surgeons. It's very difficult to standardize our workflows because no two surgeons do the exact same case exactly the same way. And then we always have this sort of internal pressure that OR time is money, and taking breaks will break our concentration and increase OR time. So I'm going to come back to that. I wanted to set the stage for you in terms of what the injuries are and why they occur, but then let's take a look at what are the effects of poor surgical ergonomics. We've heard from our panel that, one of them had to have their own surgery. Their mentors have had additional surgery. So the work-related musculoskeletal injury is the big consequence of this. And that may mean we have to take time off. We have to modify our procedures. And God forbid, sometimes people get a career-ending injury and then they can't practice anymore because they're permanently disabled. But aside from that, just being in pain and having these injuries, they can affect many other things, our productivity, our finances, teamwork, relationships. We all know we treat patients with chronic pain. We know how debilitating it can be. It affects recruitment into our specialties. It's correlated with burnout. And then more importantly, now there's emerging literature to show that surgeons' work-related musculoskeletal disease can affect patient safety and the quality of care that they're providing. So those are really important to think about, right? Because we're constantly looking to improve our outcomes. So let's look at some solutions. What are the things that we can do? For that, I want to just set up a framework. If we look at the Swiss cheese model that we use in quality and safety, it's a nice framework. And I like it because there are two things that come out of this. One, there is no silver bullet, right? I wish I could tell you that there's this one thing you can take away from this talk. If you do it, you'll have no more pain. There isn't. Often we need multiple levels of intervention, just like we needed in the pandemic. We need masks, we need vaccines, all of these things. And then the second point is that there are personal responsibilities, which we're going to talk about today, things we can do to help reduce our risk of injury. But remember, ergonomics is the interaction of humans with their environment. And so there are going to be environmental and organizational issues, particularly relating to our culture, funding for ergonomic interventions and tools, etc. So perhaps we can talk about those later. But I just wanted to set up that framework. Then we get to, well, what are the strategies? So, how do we move the needle? We can do it by sharing our stories, like you heard the panel to do it. As I said, there's a huge stigma about sharing our injuries because we're worried what it will do to our livelihood as well and what people will think of us. You know, surgeons are seen as these superheroes. But there is clearly a lack of education and awareness, even in training. We teach people to operate taking care of patient safety, but we don't teach them how to take care of their own bodies. So I want to ask the panel, you know, my ergonomics training was pretty much summed up by this one sentence, you know, stand up straight. What are you doing? You know, you're too close to the incision. Did you have any formal ergonomics training while you were doing your fellowship or residency? Did anyone ever teach you how to take care of your bodies?
Again, I will ask Maria to share her thoughts on this.
So, for my concern, I did not have any formal training in ergonomics. There was, it was maybe mentioned in medical school at some point, occupational health and such issues. I think most of these issues were raised in the practical training during residency, during fellowship, peer-to-peer kind of guidance and these comments, you know, set up straight and make yourself comfortable. So it was very informal, but it did kind of the more experienced surgeons were asking to put attention to it, which I'm very grateful for.
Wonderful. Dr. Gohil, maybe?
Yes, Dr. Geeta, formally, I haven't been trained on ergonomics, but I have learned from my own experience. I've been assisting and doing deformity cases for long hours and also working with loops, which has given me neck pain and back pain, which made me study how I could improve my posture. But I sincerely felt that it should have been incorporated during the training, especially during residency. If it was incorporated, maybe if we start early on, then it can have a greater impact.
I agree with you, and I'm going to share why. What about you, Dr. Sakhrekar?
Yeah, so neither the ergonomics nor the finance has been taught in any of the academic programs across the globe. Like I have been privileged to work in 5 continents, and none of them teach you about either the ergonomics, the occupational hazards, and all these things. So I think it's the time to start the awareness, and really appreciate your work.
Thank you. Yes. No, I agree with you. As I said, I told you what my ergonomics training was. And actually, if you look at the literature, less than 5% of general surgery programs in the US, at least when I started looking into this a few years ago, had any sort of formal ergonomics training. And now the number is better, but it's still only about 10 to 12%. So we need to do better to incorporate that as part of the training. And, you know, we in the Society of Surgical Ergonomics have been privileged to incorporate a curriculum for the general surgery residents. And then now for the first time, the Sabiston's textbook of surgery will have a chapter on ergonomics. So we need to do better in that regard, 100%. And then I find that coaching is yet another mechanism, a strategy, because like I said, you know, none of us do the same procedure the same way, and our bodies are different. And so it's nice to be able to do one-on-one sort of observations and coaching. And coaching brings an element of accountability, right? Like when people are asked to make changes, then you have a coach who's going to hold you accountable for them. So lots of strategies. Then comes, well, okay, you know, why, aside from the fact that yes, we should teach people, there is an additional rationale for education. And, you know, I think one of you in the panel pointed this out. So let's look at this. I found this article looking at orthopedic surgery residents. Okay, it was a survey of 78 residents. And if you look at them, 97% of them reported pain from operating. This is like people who are probably doing first and second assistant, right? Like they're not even the primary surgeon. And if you look at the sites of pain, back, neck, feet, yeah, the back and neck, very similar to practicing surgeons. To your point, Dr. Gohil and Dr. Sakhrekar, is that if we start early, there is a chance for intervention, right? If we start teaching these things during training, hopefully it will prevent future injury and chronic disability. So that is the reason why we are starting to talk about this. Now I'm going to get into the nitty-gritty of what are the things we should include in a curriculum or in a coaching session, or, like what are the components? Because our risks are both inside and outside the OR, we need to pay attention to intra-procedural optimization, how we position, how we set up, being aware of our postures, choosing the right adjuncts for what we need. And then I'm going to talk a little bit about breaks. And then I'll address how we can take care of ourselves outside the OR and our office ergonomics as well. So let's jump in. Intraoperative optimization. So here's a video from one of my coaching clients. Okay, I think you can pretty much tell it's an ortho case. And you can see here's the surgeon, but here's the assistant. So look at the poor surgeon's neck, their spine, and their arm, and their putting in sort of things that they need. So the point here is, if you are doing open surgery, there are some general principles. Let's start with what we mean by sort of being aware and keeping neutral posture. It's really important to keep neck flexion less than 30% or less than 30 degrees and avoid prolonged twisting of the neck. The shoulders should be relaxed, no more abduction than 30 degrees. The upper arm, the forearm should be, the upper arm should be perpendicular to the floor. The forearm should be parallel to the floor. And when you keep your forearm parallel to the floor, that's a good indication of where you should start with your table height. And I want to just pause for a moment and talk about table height here. Table height, really, the guidance is that it should be adjusted to the height of the tallest person with steps for everyone else. I want to ask the panel, when they were training, or even now when they're in practice, who sets the table height? Do the residents feel comfortable? Do the trainees feel comfortable asking for adjustment of table height if they happen to be taller than the surgeon?
Dr. Maria, what's your thought? You decide as a consultant now, or when you are training, the boss decided, or who decided?
When I was training, the boss decided. Now I'm deciding. No, it's really it's an interesting issue because I happen to be quite tall myself, and there are some surgeons that were during my training. There were the senior surgeons were maybe a little bit shorter than me, so it put me kind of in a very uncomfortable position for prolonged times, and I never did ask to accommodate for that. So yeah,
right. That's that cultural thing, right? Like there's such a hierarchy in surgery that we're so hesitant to ask, right? And so my answer to that usually for people is that I say, listen, we made the surgical culture the way it is. Maybe we can start changing it for ourselves and our trainees, So I stood on 2 steps when I was training, and I still stand on 1 step now because my trainees are taller than me. So
that's very nice of you to consider about the trainees while training. I think, Dr. Kushal, we've been trained here. Now you're boss and professor. How was your situation when you were training or fellow, and now you're the boss? How is it now?
So right now I adjust. So my height is 6 feet. So I adjust the table to my height. I bring it up to my waist level. So I am at comfort. And my residents, they use steps. So when during training, and right now also, I have a boss above me, my head of the department. So he is quite short. So when I'm assisting him, and even my residents, they get often back pain when we are assisting him because he will adjust the table to his height. So there is a problem. If the surgeon is tall, then others can get a step. But if the surgeon is shorter, the assistants, they face the problem, especially if they are a bit taller. So you have any solution for this, ma'am? Apart from
I'll
asking
come
from the
to it.
surgeon.
Yeah, I'll come to it. That's a great observation. So I mean, the bottom line is it's a cultural problem, right?
Yeah, indeed it is.
I am the boss, so I shall set the table height, but I'll come to it. So,
Yeah, definitely.
all right. So the other thing, paying attention to where we are putting our foot pedals and standing squarely on the floor, keeping sort of our pelvic girdle engaged, all of those things. And a lot of it is, things that we don't pay attention to. So once you start paying attention to it and doing it, then it kind of becomes second nature. If you're doing any sort of laparoscopic, endoscopic surgery, including endoscopic spine surgery, there are some other guidelines, right? Now here, because we're using instruments, the table height actually, optimal table height, like you mentioned, waist height is usual, forearm is typically at the waist, as I mentioned. But here the tables need to be a little bit lower, right? Because you then have your patient and then you're going to be inserting instruments. So the last thing you want to do is be in this exaggerated posture like the surgeon on the left here, because your instruments are like this and now your shoulders are abducted and raised. So you have to be able to like use your instruments comfortably. So the table needs to be a little bit lower. A big thing I see during my coaching is monitor placements, right? So our ORs have gotten better. We don't always have just a single tower, right? There are some booms. If you have those, if you have the luxury of booms and different monitors for different people, well, then adjust it so that it's right in front of you. And the guidance is that the top of the monitor should be at eye level so that you can, with a slightly downward gaze, take a look at the whole field. And it needs to be about 3 feet away from you. Of course, if the screen is bigger, it needs to be further back. But just taking some time to set up these things makes a huge difference. And then, of course, how you set up your ports. A lot of you work at the operating microscope, and I just wanted to share a video from one of my other coaching clients. This is actually a trainee. This is a fellow, and he was doing a neurosurgery fellow doing a spine case by himself. And I like the fact that they have a really nice chair, but you can see this is someone we are all taking you are all taking care of other people's spines, and unfortunately your work is putting pressure on your spines as well. So what is the guidance here? Get a good chair, like not just a stool, get something with back support and adjustable armrests. You want to adjust the chair, the table, the microscope, whatever you need to do to get neutral posture. A good idea is to tilt the seat pan of the chair. A lot of people don't realize that the chair seat pan can be tilted, so then that way you have a slight downward angle of the upper thigh, compared to the parallel. And of course, using the lumbar supports in the chair, and then consider investing in adjustable oculars. What do I mean by that? You can see that, by having adjustable oculars, you can increase this distance between the objective and the oculars. And then that kind of helps the spine be a bit more neutral rather than this sniffing posture leaning forward. So there are various things that can be done. Things may not be perfect. They may not be perfect for you and the trainee, but depending on who's doing the primary operating, it might make a difference. There's obviously a lot of chatter about exoscopes in ENT and neurosurgery. I've seen some literature like this one in orthopedic surgery as well. And basically, exoscope takes what you're seeing with a microscope and it kind of combines it with the advantage of endoscopy and puts it up on a screen. So you have a high resolution camera, you get a magnified real-time image seen on an external monitor. You can see the surgeons are kind of each looking at their own monitor, and with glasses you can get special 3D visualization. So in this study they used a survey over 1,500 spine cases. They asked the surgeons to compare the exoscope with the operating microscope. And there was a learning curve, but many considered it comparable and maybe even somewhat ergonomic advantage compared to the operating microscope. Obviously, more literature needs to be done. More studies and need to be done and published, but at least it's a starting point. It's something to consider. You might consider trialing an exoscope if you have the ability to do that. What about our adjuncts? So we talked about these things. It's important to pay attention to ergonomics in design and look for the lightest models. And then the second piece of advice that I learned from my own experience was I didn't need to have my loops on to watch people open and close the incision. I really just needed it to find the recurrent laryngeal nerve or parathyroids, so critical portions of the case. So maybe just use these headlights and loops for the least amount of time necessary. And then I think Dr. Gohil, you mentioned deflection loops are now on the market, right? They're vision up loops. They're kind of like working through a microscope. So here's, it shows that I'm looking straight forward, which kind of freaks my assistant out a little bit, but I'm able to see the field below me, and it really helps keep neutral posture. So it's worth trying if it's helpful for you. Getting sort of, ergonomics and design when you're looking at headlights. And then I apologize for this part that you can't see, but if you're using a lead apron, ergonomists recommend using 2-piece rather than 1-piece. And actually now there are many non-lead options on the market that are about 40% lighter, providing the same level of a radiation protection. So I'm always surprised why people are still using lead. A lot of the interventional radiologists have switched to non-lead options. So something to consider. Other things you noticed on all the diagrams, people are standing on anti-fatigue mats. So we use them in our homes, in our bathrooms, in our kitchens, because they're soft and squishy. But now there's good data to show that it actually reduces back pain, lower extremity pain, and fatigue in all OR personnel, not just surgeons. And it's an easy, cheap intervention to put in the OR, right? Not forgetting the importance of supportive shoes, supportive hose if you need it. Thinking about alternatives to using headlights. For example, I found that using lighted retractors means I didn't need a big headlight in the wound when I'm doing a thyroid operation. Using technology to move patients rather than human power, as we often do, and lead to injury. A word about breaks and exercises. So I have to ask the panel at this point, are you like me, where sometimes I just mumble under my breath when the anesthesiologist is taking a break and the nurse is taking a break, because it's always at the time of the case, which seems inopportune. So you just mumble under your breath. Or are you one of those surgeons who has always taken breaks, or your trainee or your mentors took breaks, and that's why you've learned to take breaks? So which camp do all of you fall in?
I request Maria to share her thoughts.
So I was just trying to remember if I ever took a break during a surgery, but not first.
I hear you, Dr. Maria. Yeah.
Kushal, if you could share your thoughts.
So even I haven't, even during long surgeries, we have been trained that we continue the surgery rather than taking a break, even not for the meals also, not for the loose. So before the surgery, we are all prepped up. And after 8-10 hours, especially in long deformities, we are washed up. So usually we have not been trained to take breaks.
Right. Again, it's part of that culture. What about you, Dr. Sakhrekar?
So again, I had very experience. So one of my bosses is from Toronto. Like we used to do only neuromuscular and complex cases. And before the start of the case itself, he usually like 3 surgeons, me as a fellow, his staff, and as a resident third person. So we used to start at 8, and he used to mention at 12 o'clock, resident will be going on a break for 20 minutes at 12 to 12:20. And then Raj will go on a break from 120 to 140. And then I will continue, and he will take break from like whatever, 2:30 to he will take short break like 2:30 to 2:45, like 10-15 minutes break. And we'll go bang on during the time of closure around 5 or 6 or sometimes 7, 8. So he had that schedule that everyone will take 15-20 minutes breaks in between. And that really helped, I feel, for the second surgery of the day, I feel, for the recovery. So this is one of the different experience, but rest, all surgeons, even I myself feel sometimes the momentum is the key, and we just keep marching ahead and finish the case. So both experiences, I say.
I see. I love it. The panel has such diverse experiences, and I've also done my training at the University of Toronto, and I think Toronto did a better job now that I look back about thinking about these things. So just like for your cases, my long day is total thyroidectomy, central neck dissection, bilateral, lateral neck dissections, that's like a 10, 12-hour day, right? So I'm here to share the literature that blew my mind and then what I put into practice, and hopefully you all can think about it as well. So we know that taking short breaks is helpful. We know that doing exercises is helpful. But this study was done by kind of the guru of surgical ergonomics at Mayo Clinic. This is Dr. Susan Hallbeck, and the Human Factors Lab there. So she took 56 surgeons, different institutions, and they were asked to incorporate breaks and exercises while sterile. And they looked at the end result. And, contrary to what one might think, that momentum, that concentration piece, is it going to break the concentration? In fact, 88% of surgeons reported improvement or no change in their concentration. And of course, 100%, as Dr. Sakhrekar said, reported improved physical performance. And the best news for all of us and OR administrators everywhere, the OR time wasn't prolonged. I'm so glad she included that variable. In fact, the study was so successful that most surgeons wanted to incorporate it into their practice. So she worked with ergonomists, physical therapists, and occupational therapists to develop this OR Stretch app. You have the QR code here. It's a free app. You can go on it. Now, I'm showing you the app as a way to get started, but really you could take breaks and do this, based on your own clock or whatever. The point is that you need to take a break every about 40 to 45 minutes. The muscles need a reset, and it's not enough just to kind of lean forward and lean back and go, oh, and then go right back in. You need to take a break for at least 30 to 60 seconds for the muscle to reset. So this app is one way to do it. It'll, the alarm will go out in 45 minutes. If it's not a great time, you can snooze it. Otherwise, it runs you through a series of stretches, which take anywhere from 60 to 90 seconds. You can do it sitting, you can do it standing. As I said, you can use this as a mechanism. So I urge you to take a look and try it out. Breaks not only increase sort of our physical well-being, as you heard from Dr. Sakhrekar, but there is data to show that it improves that concentration and the speed and efficiency of the next part of the procedure. And I've experienced this myself because there is a whole other field of study called cognitive ergonomics, right? When you're focused on something, you get tired. Sometimes when I'm hunting around for the recurrent laryngeal nerve and I can't find it, if I just step out, take a quick break and come back, it's much easier to find. We get into those cognitive holes. Now, what about outside the OR? Well, we are not very good at following the advice we give our patients, right? Take care of your bodies, but we need to. Exercise is crucial. For those of you that are runners, fantastic. Your heart is in great shape. Good luck to you. If I'm caught running, I always say, look at the animal running behind me, because that's the only way I'll be running. The important thing for us as surgeons is to incorporate some sort of stretching and strengthening routine, because we have to undo what I showed before, the end results of the forward head posture. We have tight anterior muscles and we have weak posterior muscles. So you need a program that will stretch these and strengthen these, and a similar thing in the lower back. Whether you do it with yoga, Pilates, working with a personal trainer, using bands in between cases in the call room, whatever you want to do, some sort of these two elements need to be present. In fact, there is literature to show that if you have a preventative stretching and strengthening program, it reduced back pain and analgesic use among general surgeons. But I also found an article where they have tried it in orthopedic surgeons. So just in case you say, well, what about orthopedic surgeons? It improves it for all comers. The Society of Surgical Ergonomics, the American College of Surgeons, Ergonomics Task Force, they all have resources about how to take breaks and how to do these stretches and stretching programs. So please feel free to take a look at these resources. What about our office setup? Just like setting up your screens for endoscopic procedures, here too, the table needs to be at the correct height, your upper arm, shoulders need to be relaxed, the forearm needs to be parallel to the floor, you need to have a good chair with lumbar support. So maybe getting an ergonomist or a physical therapist to come take a look at your office setup is helpful. We all love using laptops. They're not very good though for spine health. And so if you have to use a laptop, it's a great idea to get a laptop riser so you can bring the screen up again to eye level, and then using an external mouse and keyboard. The intrinsic mice are very stressful to the arm. I switched exclusively to voice recognition at the worst of my pain. I couldn't stand to type. And then just paying attention to your posture and ergonomics when you're outside the OR, doing your hobbies, etc. All of those things kind of add up. Our injuries are from life. Work is a huge component, but it's from life. What are some things on the market that might help? Here's something called exoskeleton. You may have heard of it. It's passive or active. Passive exoskeletons are non-powered devices that rely on energy storage in elastic parts, and then they support the user's body segments during awkward postures. Here's a commercially available exoskeleton on the market, and I only put this up there because there's a study, it's actually now published. It goes on like a little vest, but you can see that there's a helmet like you have for a headlight, but you see there's this rod in the back, which is really not uncomfortable, and then you have this kind of elastic band kind of attached from this headpiece to the bar. And I put this thing through its paces, like I disobeyed every ergonomic principle. And my findings were similar to what the study found, which is they had surgeons use this, and they used the NASA TLX to assess workload and usability questions. And it actually reduces the time you spend in extreme neck or high risk postures. And so the risk goes from high to moderate, and it doesn't interfere with workflow because it goes on just before you put on your scrub suits. So something to look at if, because we can't maintain neutral posture all the time, right? So something to help that. Now, this piece that I promised Dr. Gohil that I would address, the culture piece, right? We really do have to address the hierarchical problem in the OR. With respect to table heights and other things. When we ask for anti-fatigue mats, sometimes people will say, oh, you want the princess pads. Well, actually, I'm an empress in the OR, so I like to call them empress pads. But the point is that, that language may dissuade people who are hurting from actually using it. So let's call them what they are, anti-fatigue mats, right? Perhaps we need to look at having mechanisms for early reporting, so that people can get PT referrals, etc., before they have their injury. I suffered for 6 months with back pain, not being able to tell anyone until my disc herniated. Maybe it wouldn't have happened if I'd gone in earlier for physical therapy. I don't know, but certainly something to think about. And then this whole culture piece, we are a team in the OR. We can look out for each other, look out for the resident can look out for the student, and we can all look out for the nursing staff as well. And something that the Society of Surgical Ergonomics is working on is like coming up with a little ergonomics checklist and a timeout. We do timeouts for patient safety, and perhaps taking 30 to 60 seconds to make sure that we have the monitors where we want them, we have the anti-fatigue mats, the pedal is where is it, might go a long way to improving our ergonomics. Thank you very much again today for the privilege of this podium. My email is up there. I actually host a podcast on the topic of surgical ergonomics. It's called the Surgical Ergonomics Podcast. You can find it everywhere on all the platforms as well as YouTube. Feel free to do that. You can join the Society of Surgical Ergonomics. We have all materials, educational materials, symposial recordings, etc. And then my email is up there if you have additional questions or want to reach out regarding lectures, workshops, and coaching, etc. So thank you once again to all of you, and especially the panelists and Dr. Sakhrekar.
Thank you very much. It's really a privilege and honor to have you, and it was a really wonderful talk. And I invite the questions now. Dr. Maria from Israel, orthopedic spine consultant. She having such a vast experience, I request her to ask any questions from her end, and followed by Dr. Kushal Gohil. Yeah, Maria, you have any questions for Dr. Geeta?
So yeah, first of all, thank you for the it's a very relevant talk and very interesting points you brought up, very useful. So I would like to ask, in your experience, what is it that would change what would actually change the surgeon behavior or make us force us to put more attention on the ergonomics? Is it the availability of instruments? Is it instrument design? Is it maybe is it education? Is it institutional policy? What is the most effective measure?
Dr. Maria, that's a great question. Thank you. I think my sort of initial brief answer would be, all of the above, right? Because we are so sort of on the left side of where the needle should be, right? That any effort we do will be, much needed and well received. So that's why I kind of put it as, multiple strategies, right? We do need more education and awareness. For that, we need to share our stories and make it okay to discuss in the operating room, right? I share in the operating room, listen, I stopped using loops because I'm hurting, and this is what I did, and this is why you need to pay attention to the table, right? When we're younger, we think we're invincible. Our trainees think they're invincible. It's not going to affect them. But if we can, we're telling them how to dissect, a tumor off a nerve carefully, we can share that experience with them as well. Policy change is huge, but that involves getting together multiple stakeholders, which is not impossible, and showing departments and administrators that this is not an optional thing. Healthcare workers, not just surgeons, but surgeons, other physicians, nurses, are just used to making do. And when it comes to policymakers, we need to show the financial advantage, right? If you lose a surgeon in mid-career when they're the most experienced to an injury, it takes a lot to replace that level of surgeon. And, this is an investment in the workforce in a time of problems with accessing healthcare.
I request Dr. Kushal to ask any questions or any comments he has regarding the same.
Sure. Thank you, Dr. Geeta. That was a really enlightening presentation. So I was really intrigued by the exoskeleton which you showed. I hope it is commercially available in India. I would definitely like to try it. So
Right. Thank you very much, Dr. Gohil.
based on your yeah, please carry on.
No, you had a question. Sorry, I interrupted. My apologies.
So yeah, this was interesting. And so based on your extensive work with surgeons, so what is that one ergonomic habit that most surgeons tend to ignore? I am in early phase of my career, so which will have a very big impact in the long run. So I want that one habit which I should change, or most of us should change, that will help in the long run. So what would be that according to you?
Got it. Again, very very poignant question. And I know I gave like a whole, menu of options that we can do differently. I think the biggest bang for the buck, if you could change one thing today, is taking the breaks and resetting your posture. Okay. So we can't always be in neutral postures, right? Because that's just the nature of our work. But just taking those few minutes, as Dr. Sakhrekar mentioned, at the beginning of the case, just setting kind of the expectation that, like his mentor did, that, at this and this time, this person will take a break when it's going to be a long case, right? I will say, when the thyroid is out and the lymph nodes are out, I will take a break. The student will go first, and I and the resident will keep operating. Then the resident will come back, and then I will go. So you set the expectation and you do it. Taking care of your biological needs, so you can use the bathroom, you can stretch, you can eat something, and you can come back, will just make the next part of the case be more efficient and the team work to continue uninterrupted. And so that would for if I had to name one thing, I would say that would be the biggest bang for the buck. And it's nothing that requires an investment. You just need to commit to taking a break. And I find that the trainees are very good at propagating these habits because they'll go to another room and work with a partner surgeon and they'll say, well, Dr. Lal uses anti-fatigue mats. Can we get them in this room too? Or Dr. Lal takes breaks, So culture is infectious, right? These small habits are infectious.
Definitely. So we tend to overlook all these things. So we should start
You don't, yeah.
incorporating. Yeah.
Yeah, I mean, I liked using the exoskeleton, but it doesn't have to involve, making small changes doesn't have to involve big investments, right? Since Dr. Sakhrekar said this is not a CME conference, the exoskeleton that was studied in here is called Neckspine, Neckspine. So if you're interested in looking, you can look at their website, or I'm happy to, send that information if you require.
Thank you. Just like I have one question before we end, or any comments from Maria or questions. So, as the first time, the Sebastian thought we should include your topic about the ergonomics, and huge congratulations to you and the Sebastian also textbook of surgery too. That the topic is included. Also, being you co-founder of the Surgical Ergonomics Society and the past president. Now, what's your thought down the line in future? How the awareness will be created and ergonomics, where it will be in 5 or 10 years down the line, or your thoughts on it?
Wow, that's quite a profound question. I'll say that our hope, at least when we meet in the society, and I have a meeting for the society just following this, I'm still involved in the membership committee. Our hope is that we may not need a society of surgical ergonomics 5, 10 years down the line, because we want it to be kind of standard operating practice. I mean, just like our instrument trays come to the OR, our anti-fatigue mats and, other equipment that we need should be there. And maybe as we entrench this in our culture, that it's okay, we look out for each other. Because I'm the professor, I don't need to make you suffer by, because you're taller than me and things like that. Just doing that in one generation, I think or 1 or 2 life cycles of residency will hopefully reach a point where we don't need to be talking about this. It's accepted practice.
Great. And before we conclude, the last question and the comments from Dr. Maria will take, and up with your answer, I will just conclude because we are running out of time. So last question and comments from Dr. Maria Auron.
Yeah, thank you. And so just a quick question from the female perspective, as more and more females also are getting into orthopedics, still rare, but we're improving, also in spine surgery. So do you have any comments on pregnancy and ergonomics?
I appreciate you very much for bringing that up. I usually talk about it, but it depends on the time available and questions. And I appreciate that it always comes up in the questions. There isn't great literature supporting or making any sort of recommendations for pregnant surgeons, but we recognize extrapolating from the nursing literature that pregnancy has inherent increased ergonomic risk, again, because of, let's say, the shifting of the center of gravity, right, as pregnancy advances for the lower back. And then also relaxin, estrogen, et cetera, change the flexibility of our ligaments and again make us more prone to injury. There are multiple studies ongoing right now to try and come up with sort of recommendations regarding proceduralists during pregnancy. Some things to consider, for example, are given the increased risk of wrist pain and hand pain and carpal tunnel syndromes, perhaps reducing the amount of endoscopy things that people do in the third trimester, taking breaks every 2 hours or so, scrubbing out, hydrating, things like that. So there aren't any formal recommendations, and which is one of the other reasons to kind of join the society and advance the field forward. The other thing to do with female or proceduralists who are women, I mentioned kind of the instruments not being designed for a wide range of anthropometrics, right? Now, I'm not saying that male surgeons can't have small hands, but more than likely, women surgeons are the ones who are going to have the smaller hands. And so that's something else the Society of Surgical Ergonomics is trying to address through the Industrial Relations Committee. We're trying to work with instrument design to understand what goes into sort of the size, how they determine, the size of the handle or instruments, and can they be made in multiple sizes, etc. So I hope that answers your question and that was helpful.
That was
Thank
beautiful
you.
answer and beautiful question. And you have, Kushal, any comments or any questions?
No, that was really enlightening, and I hope this makes our life a bit easier during operation, the entire talk. So I would like to thank Dr. Geeta for such a great talk, and also Raj for the opportunity.
Thank you. Thank you. So with this, I like to really thank Dr. Geeta Lal. Phenomenal talk. This is something new and very important, very less talked about, very less discussed about. And the work you've been doing, really appreciable, commendable work, and hope to work in collaboration in future. I'd like to thank Dr. Geeta Lal, our speaker, as well as panelists, Dr. Kushal Gohil, Dr. Maria Auron from Israel, and Dr. Maria Camila. Unfortunately, she had emergency surgery. And also like to thank our Ortho TV staff, Rishi, Ms. Poonam, and our mentors, Dr. Neeraj Bijlani and Dr. Ashok Sham, and all the viewers of the Vertebral View show of the Ortho TV and Spine TV, who inspire and encourage us to share the knowledge. Thank you. Thank you very much. That's a wrap. Take care. Have a good day.
Thank you all.
Thank you, everyone.
Thank you.
Bye-bye. Thanks.
Maharsh, you can go offline.